Good afternoon, everyone, and a warm welcome to our season finale talk show, Let's Talk Primary Healthcare. My name is Melita Jakob, and I'm the head of the WHO European Center for Primary Healthcare. Today's talk show is a special edition. We will not be deep diving into a technical discussion. We will not be sharing with you data, evidence, resources, and tools. We will do something much more important. Today, we will listen. We will listen to the voices of young health professionals who chose primary healthcare at the end of their training. I very much look forward to seeing primary healthcare through their eyes, to be inspired by their passion and by their fresh ideas. And I also look forward to understanding the challenges they face on a daily basis. The future of primary healthcare is in their hands. As usual, we will start with a one-hour panel discussion, and then we invite you to 2 breakout sessions, one in English and one in Russian, to hear from you and your experiences. In the meantime, please use the chat, say hello to us, and share your questions and comments. And with that, I would like to welcome and introduce our panel. Shirin Talabekkizi is a family doctor in Kyrgyzstan who completed her 2-year residency in family medicine and is now working in a family medicine center in Bishkek, as well as at the medical academy. Stephanie Funder is a nurse specialist in community and primary healthcare in the city of Kalundborg, Denmark. Katja Sako is a young pharmacist who practices in a community pharmacy in Malta. And Andrei Puris is a last-year student of social work at the University of Bucharest in Romania and works in an NGO that provides essential social services for homeless people, injectable drug users, and sex workers. Thank you for joining us today and being part of this conversation. And let's get our first round underway. I would like to understand what motivated you to join primary healthcare. And let's start with you, Shirin. What were your motivations to become a family doctor? We know that in Central Asia, many young graduates dream about becoming specialists.
Yes, hello everyone. You are absolutely right that every medical graduate dreams to be a specialist, and even me. But due to some conditions, I was enrolled to family medicine department. And, you know, at the very beginning, I was also thinking to switch my specialty to the another narrow specialties. But I had one life experience that changed all my view, and it was related to my family medicine, to my family member. And at the beginning of the residency, our mentors were talking about the family medicine principles, but I was, listening in perceiving all these things very abstractly and skeptically, as everyone in my course. But after my personal experience, when my family member should go to the up to 5 different specialists and still didn't get to receive the appropriate care, and every specialist was treating just one side effects of the main disease, and it led to very sad outcome. And after that, I understood all the things that our teachers, our mentors was giving us about the principles of the family medicine, and that really in our healthcare system, we lack this holistic approach, this coordination role of the family doctor, and comprehensiveness and patient-centered care. And that's why I changed my mind to stay in family medicine residency and become family doctor. Thank you.
That's a very moving story. Let's come to you, Stephanie. As a young nurse, why you chose primary healthcare for your workplace? We know that the nursing workforce in our region is disproportionately aging. What were your motivations?
I really wanted to be in a workplace that allowed me to see the patients holistically, just like Shirin said. I wanted to be able to make a difference in the patients' lives in the average day. I got inspired by the opportunity in primary healthcare, the opportunities to be a generalist. I was also deeply impressed by one of my mentors during my training. She was so competent, she was so caring, and really made the patients feel safe. And that made me feel like I could do. This was a place that I could do a lot for the patients. And to be the advocate for the patients when they can't do it themselves, to help the elders navigate through the really complex healthcare system. I had one reservation, and that was that many of my other mentors and many of my fellow nursing students didn't really think that it was fitting to be in primary healthcare as a new nurse. It was and still is seen as a field for elder nurses who has a lot of experience and who are trying to step back before retirement. This is mostly because many don't know what it is that we do in primary healthcare nursing. And I just knew that this was where I wanted to be, and this is where I could see myself, and where I felt like I could really make a great difference for the patients.
That's very interesting path. Andre, let's come to you. As a social worker, you're working with vulnerable people, and often you're their first contact for whatever help they need. What made you choose this line of work?
Hello, everyone. I got inspired by the fact that I have seen these people, like homeless people or injectable drug users on the streets, and mostly all of them somehow are excluded, are marginalized, are discriminated by the society. And I somehow wanted to show that these people are people like all of us, but no one, absolutely no one, knows what their stories are, what they were going through, and ended in this kind of situation. Also, before knowing that I want to make a change on this specific line, I have seen like people in the streets, and I was thinking that this shouldn't be seen as something normal in the society. And every person, I really think that every person deserves a home, deserves help and support, so they can have their human dignity.
Thank you very much for that. Katja, let's come to you. As a community pharmacist, you are part of the network of care, of primary health care. What made you choose this line of work?
Hello, everyone, and thank you for letting me participate. Yes, my primary motivators were to alleviate the medication-related burden of patients, especially patients who had polypharmacy and comorbidities, and to make an impact on their quality of life, as well as support their relatives who are helping them. And sometimes they are not trained to help their sick relatives, but they seek their support from us pharmacists in the community. And those were my primary motivators, yes.
Thank you very much for that. We see 4 different countries, 4 different professions, 4 different paths to choose primary healthcare as a workplace. And yet your stories are all connected by the desire to help people, to support people, to work at the community level, to provide holistic support to people, regardless of the main conditions they're turning you to with. How does practice match your inspiration? Clearly, each of you have very strong vision why you chose to go into primary healthcare. You have each been working in primary healthcare for a year or two. How has practice turned out? Are you able to realize your vision? And Katja, let's start with you now in this round, right? You mentioned community embeddedness and connectedness. These were very important for you to become a community pharmacy. How does practice meet your expectations?
Yes, as a community pharmacist, I managed to build a rapport with the patient and their families because you meet them a lot. They come to the pharmacy often. And when they are regulars, I learn their family and their medication history, and I would be better in a position to help them as well as provide them a holistic approach and move forward from the patient-centered approach to the family-centered approach and target the needs of the family as well as and their carers. For example, if you know that the patient is bedbound and he's suffering from stroke and he cannot swallow and he has been prescribed a particular medication, as a pharmacist, I try to alleviate that burden and try to find something similar or the same, a drug formulation that either bypass the swallowing, like patches, for example, or make it easier for the patient to swallow, and that facilitates even the work of the relatives as carers. It's not so easy. I mean, meeting the patients, yes, it has met my expectations, but there were also some barriers. Sometimes you don't, we are all alone. Because you are alone in the pharmacy, you're the pharmacist, and it's isolation, you know. You don't meet up your other peers to contact the doctor or other pharmacists, but we managed to bypass that with a WhatsApp group. So yes, we have a lot of paperwork, unfortunately, which has to be done by us, which eats up the time with our patients. And there are also policies and laws which do not let us give the service that we really want. We wish to do more to the patients rather than just providing the medication. And sometimes the lack of direct communication, for example, with doctors, if we have problems with prescriptions, we have to find the doctor, telephone, etc., to find to talk to the doctor and try to help the patient.
Thank you, Katja. You mentioned some really important themes in your narrative. First is to see the patient in their social context, in their family context, and support the whole family, not just the individual. The second one is to be a bridge, really, between the patients and the specialists by changing and narrating some aspects of care. And the third one is to be connected as a professional into a broader network. And we see this very, very strongly, that often we see individual practitioners, especially in rural areas, either pharmacists, but could be a family doctor or a nurse. And this lack of connectedness, lack of being able to discuss with someone is a major sense of demotivation. So I think these are very, very helpful points that we need to think further as we go forward in strengthening the model of care. Shirin, I'm coming to you now because you had a very clear vision why you entered primary healthcare. You wanted to provide holistic care and overcome the fragmentation of over-specialized services because it is not good for the patients and it does not lead to good outcomes. Are you able to do this? You have been now practicing as a family doctor. What are the challenges on the ground to providing holistic care?
Yes, thank you. Yeah, I was able to do many things, but also I met some kind of challenges, and the things that I could provide, it was the management of the comorbid patients and they were really happy to visit just one family doctor instead of going to the 3 different specialists and spending the time. And also one thing that I benefit working like a family doctor was that people began to trust and especially women were coming just to discuss their family issues, family problems. And it was very helpful for me to diagnose some kind of psychological disorders like depression, like anxiety, etc. And the other thing that the members of the family were coming wholly, the mother, father, and the son, and sometimes they were taking their grandmother, grandfather, because they like to visit family doctors. But the challenges was that it was not received in first contact visit. It took a real long time to get the trust of the patients. And but after a few visits, they also understood and the continuity of care, and they were preferring to go to family doctors.
Thank you, Shirin. Very good. And Stephanie, you had very similar motivations, as Shirin mentioned, to see the person holistically and provide comprehensive care. How has your experience been in the first years of your practice?
Well, it kind of met, but I am right now. I'm in a team of, we are about 28 nurses. The community group, both in age, experience, and interest within the field. But I met a complex task. We as primary healthcare nurses have a central role as coordinators for the patients. For example, when we have a patient who receives practical help, then I have a patient who are in dialysis 3 times a week, goes to checkups for her heart and with the GP, and then also has a physical therapy, has a little wound, has some medicine we need to help her with. Our job is mostly to ensure that these different appointments are coordinated so they don't happen at the same time, but also to facilitate the transport and make sure that the patients actually go to these checkups and go to the physical therapy and the dialysis and all that. And in between, get the practical help and then the nursing help that they need. And we also have a big task with communicating between the different parties. This especially with the patient who can't deliver the information themselves, or who can't navigate through the system that well. So the reality I met in primary healthcare was an immense complexity, both with the patients, because the patients are getting more and more complex, but also within the organization. And I think it was a complexity that I wasn't totally aware of beforehand. It is also a complexity with so many elders. We have a lot of, most of the patients we have are elders who can't navigate through the technological advances that the healthcare system has taken in over the past years.
Indeed, and we will get back to some of these points later. Andre, you entered your practice of social work during the COVID-19 pandemic. What were the main challenges of transitioning from theory to practice?
Yes, during COVID-19, it was really difficult for all of us to do our job. And it was necessary to rethink our actions and to have access to new resources. I think that no one was really prepared for this pandemic, especially social workers who are working in the front line. And I truly believe that at least in theory, we could have been prepared for what came. And we should have known, at least on a basic level, how to work and how to do our job. But also practice has proven us that we can adapt and we can still work on a high level. But think about how it would have been if we were prepared. So yes, I think that always there is a place for improvement.
Yeah, so it sounds like each four of you had strong inspirations to go into primary healthcare. Your practice has continued to fuel your inspirations, but you have also encountered some challenges. And it sounded to me that some of these challenges were system factors of how primary healthcare is designed, but some of them relate to your education and how we educate health professionals for working in primary healthcare. Looking back, how do you evaluate your training? Was it fit for purpose? Did it prepare you for the practice that you're finding yourself in? And I like to do this as a rapid fire turnaround, each of you just giving us 2 or 3 bullets of how could your training be made more fit for purpose for the practice that you're finding yourself in. Andre, let's start with you.
Yes. I really think that it's important to have a mentor. I was lucky and I had a mentor, but not every youth social worker has one. And I think they should have, because having someone that can help you when you don't know how to approach a situation, it's kind of crucial. Also, I met people on the streets who are asking me about services that they can have access to. And the services I can talk about are just a few and not enough to cover all their needs. So it's important that students nowadays to be taught how to create and how to develop social services for the community.
Katja, let's come to you. You're next.
Yes, the pharmacy course was good, was fit for purpose, yes. But if I may polish it a bit, I would add some psychology lectures, because as pharmacists, we are the next stop after the doctor, especially when patients are given a bad news about their health. So it would help us as pharmacists to be able to counsel and advise the patients, also be able to advise the drug users and give them the best care, because we don't want to send them back to the streets without the care that they need, and their care is different from the care of other patients. And also we are becoming very multicultural, and it would be best if we would know more about other cultures and their perspective towards the medications, so that we would know how to address them.
Stephanie?
Yes, for our training, I think extending the amount of training happening in primary healthcare now is most of the training, as far as nurses go, is in the hospitals. I myself had 6 weeks of training in primary healthcare during my nursing student time, and I think extending the amount of training in primary healthcare would definitely help. Also, maybe introducing a little more organizational theories and into the training would help prepare nurses for the work that is needed in primary healthcare.
Very strong point. Shirin, you will close this round of discussion.
Yes, thank you. I'm fully agree with Andrea about mentor. It's really important for young professionals have a good mentor, so the mentor could provide and motivate you during the first years, especially. And the second, also, I would benefit from the interprofessional training, like if you could involve. Also the social workers, nurses, and other neurospecialists, and work more on practical cases and just discuss the really practical cases and to see everyone's point to better understand each other. And another thing what I would like to say it's to have more hours on communication skills, like soft skills. And the other point, which is very likely in our country, is to make some hours on burnout, on professional burnout prevention, especially for young specialists. Yes, thank you.
Thank you very much for this round. It sounds like you were all lucky to have very good training in your professions, in your countries, but there are a few very nice points that you're bringing out for the future of training for primary healthcare to equip you better. First, to make it more interdisciplinary, interprofessional, as we are moving towards multidisciplinary practice on the ground. It's very important that is how training takes place, and in particular in the areas of integration of health profession with social work and mental health. Very, very important point. I also appreciated the point that it's not just the medical knowledge that you need to learn, but also non-clinical skills like communication, I think was mentioned, but also advising and counseling on behavior change, etc. That's also very, very important. And it's important to take some of the practicalities and the practice not in a hospital setting, but where you're actually going to practice your work in the future, so that you also get a full understanding of the institutional relationships and organizational support. And finally, I like this idea of mentorship. I think all of us remember very fondly of our mentors, and they've played a very important role in all of our professional growth and career. So I think somehow institutionalizing some personalized guidance in early years of training can be very powerful and very helpful. So thank you for bringing those points to bear. And now I'd like to go more deeply into looking into the future of primary healthcare and get your fresh ideas of how we can overcome some long-standing barriers in strengthening primary healthcare. For example, we always talk about the issue of prestige, that no matter how much we invest in primary healthcare, the population may not view primary healthcare with enough prestige. Health professionals who are not working in primary healthcare are not viewing primary healthcare with prestige. How can we enhance the prestige of primary healthcare? We have a big issue attracting health workers to the profession. How can we attract more health workers so that people will be more like you guys, that you finish your training and you choose primary healthcare as your workplace? What can we do to do that? And many of you mentioned that you were attracted to primary healthcare to provide more integrated and holistic approaches. At the same time, you're facing serious barriers. The population is resisting it. Some of the narrow specialists may be resisting that. How can we overcome these? And you're welcome to weigh in on whichever question you want. I'm going to give you some prompts, but feel free to go beyond what I ask and share some of your other thoughts. Shirin, we're going to start with you. And in our preparations for this talk show, you mentioned multiple times the issue of prestige of primary healthcare and family medicine in particular. What would be your suggestions? How can we enhance prestige of primary healthcare and family medicine?
Yeah, thank you. First of all, I would like to have that family medicine could be recognized as a scientific discipline, because it's like a great motivation for a young specialist to make a career, firstly, and secondly, it would be a great also to make some research at primary healthcare level, maybe just to measure the complexity work of the family doctors, and just to show that family doctors are really benefiting, really give benefits, and it really cost effective, also really effective. They receive really effective care. And secondly, to raise the prestige of family medicine at the leading positions at a ministry level and at the policy level, we should put practitioners from primary healthcare professionals, so they could be involved in making decisions at the policy level. And also the other suggestions is to ask the local authorities support the family doctors, young professionals, and so I think that's all for now.
I think those are very, very good ideas, Shirin. I like them very much. And I may come back to you and ask you, is this happening in Kyrgyzstan after we conclude with the others? Stephanie, you started your narrative by noting how challenging it is to get nurses in training to choose primary healthcare. How would you overcome this barrier?
Yes, I think some of my thoughts are that we need to get better at promoting the primary healthcare. We need to get better at promoting already when they're in nursing school, start to promote the primary healthcare nursing. What is it that we do in primary healthcare, and what is the opportunities for a young nurse or new nurse to be in primary healthcare? We also should look at the mentors in primary healthcare. We need some really good and strong mentors who are ready to embrace the nursing students in primary healthcare, and it should be attractive to both be a mentor in primary healthcare, but also to be in primary healthcare. A little bit like Shirin says, it should be recognized as a specialty, because being a generalist, as we are in primary healthcare, is a specialty. And it should be recognized as such. But also getting promoted into the nursing community, what it is that we do in primary healthcare nursing, and what is it that is so giving in primary healthcare nursing. What is it that we are able to do that makes it attractive to be here, to be in primary healthcare nursing? We need to be more outspoken about the work and really reach some more both students and nurses. Yes.
Yeah, no, I think those are very good points, and you reinforce very much what Shirin said. And we in fact know from the example of countries that have successfully promoted and raised the status of family medicine, that family medicine was indeed made into a specialty, and it's also reflected in the remuneration of health professionals. So I think that's quite important and quite clear. Stephanie, may I stay with you for a moment? You mentioned that it's important to promote the profession and explain better what the work of primary healthcare is. Are you doing this kind of work? What kind of forums are you engaged in to promote this, or what can we do to do this?
I think it's right. Let me start at the nursing schools. Me and a fellow mentor for the students here in my area has went to the nursing school and actually talked about what is it that we do, what can we offer, both as a place of training, but also afterwards. We also try and recruit the trainees that we have, the nursing students that we have, try and make them stay after their training or come back. As for the nursing community, getting involved in the unions and really speaking about what is it that we can do. Now in Denmark we have a new specialist education for community nurses. Also getting that promoted and getting that specialty is really important, because we also come out to the hospitals and come out different places where we can promote our work.
I agree. I think it's also giving me a lot of food for thought of how we, as for example WHO, are promoting primary healthcare and in what way. And it's very difficult and very challenging to actually explain that complexity, right? Because primary healthcare is working on everything, all conditions, and more holistically. And it's very difficult to translate that into attractive and understandable pieces of what is it that primary healthcare does. But we need to invest much more into this and need to step away from the stereotypes and make it attractive for both the people as well as for future health workers. So I think that's a very good point and good food for thought for all of us. Katja, let me come to you and let me return to a thought that you mentioned early on, which is that community pharmacists are part of a wider network of providing primary healthcare services. And it's really challenging to make this network work as a network, right? To be connected within this network with other professionals and not to be isolated. And that was one of the challenges you mentioned. How do you see some potential solutions to strengthen this connectedness among various health professionals at primary healthcare level?
Yes. I suggest that there would be some sort of direct contact, like Zoom or Skype or a WhatsApp group, that if we have a problem with a prescription from a doctor, we can easily contact that doctor or a social worker to help the patient, without going through the bureaucracy, without going through the searching the directory to get the phone call. So that would it would be less time consuming and it would be more confidential, because we are not speaking indirectly in front of the patient, but we maybe do it in privately in our offices. Taking you back a bit about prestige that you have mentioned, I would like that pharmacies also shift from the idea of sales girls in a shop, because pharmacies, normal community pharmacies, are owned by private. So we are there to push the sales up, but no, we are not sales girls. We provide care to our patients. We have that extra value to give to our patients, to our clients that seek our help. We have seen it during the pandemic, during COVID. We were, besides grocers, we were the only ones open to help the patients, and we have actually managed to help them, especially when they were panicking. And we helped them to sift through the information that they were being bombarded with. And I don't wish that we lose it now that maybe we're getting over this pandemic, but we remain actually relevant to the primary healthcare, because we can do a lot. We can do more activities, more screening in our pharmacies for colon cancer, for example, more point of care testing, given the facilities, given the access, given the trust that we have already from the patients and the authorities, then we can do much more than we are, and we can help the primary healthcare, and also we can lessen up the burden on hospitals and on governmental clinics.
Yeah, thank you, Katja. Those are very, very good points. And certainly about working in networks, a key issue is communication, right? And today with technology, we're in a much better position to communicate across different professionals. But we also see that it's very important to have a responsibility for population health management at the network level, and a quite clear sort of management structure to bring the different providers together and maybe even hold regular discussions how to achieve those goals. So, and then on top of that, communication can be very, very helpful. That's a very good point. And I'm really grateful you returned to the issue of prestige. I think this is a recurring theme in this talk show. And I think you mentioned very similar themes as both Shirin and Stephanie mentioned, is that professionals at primary healthcare level can do a lot more in many professions, whether it's family doctors, nurses, community pharmacists, to be oriented to population health, expanding their role in health promotion and prevention and screening and disease management in a holistic way. And to do this well, that needs to surface in the training, in the guidelines. And if all this work is done well and the quality of primary healthcare is strong, that will feed back into prestige. So I think these are complicated topics that are all very, very much interrelated. And you have done a very nice job bringing it out. Andrea, I'm coming to you as a social worker. Please do comment on this issue of prestige as well. From the perspective of social work, it's very, very interesting. But my specific question to you, with somebody who works with the most vulnerable in our communities, how can primary healthcare become more effective to support the vulnerable?
When I am thinking about the situation in Romania, I am thinking about the people I work with. Most of them, almost all of them, they need primary medical assistance. Also, a lot of them don't have identity papers. They don't have health insurance. So it's really difficult for them to have access to health services. So yes, I think this is how it would be more effective. Like, these people can really have access to health services like all of us. And another idea that came to my mind is based on the fact that maybe the existence of a mobile team that can go in the streets, and this mobile team to be formed of doctors and nurses would be also effective, like to provide this kind of services to people where they're at, because they're like in an emergency situation. So a doctor and or nurse to be there for them, I think it would be more effective. Also, I want to talk about creating special places for injectable drug users, for drug users, because now I'm talking about harm reduction and the importance of harm reduction. So I'm thinking about these people to be assisted by a specialist like a social worker. Why not? So they could use use drugs without any harm. I think these are my suggestions. Thank you.
Yes, thank you. And I think you raised a very important point that often there are administrative barriers to seeking care, and we don't often think about this as much as we think about physical barriers like distance or financial barriers like cost. But often we don't think about administrative barriers like the lack of papers or knowing whether somebody has or not the right to seek primary health care. And certainly we see this among the group that you mentioned, very extreme vulnerabilities, but we also see it among groups, for example, migrants, internal migrants who move from rural areas to urban areas and settle down, or international migrants. So this is a very, very big issue. And here is where the health sector alone is insufficient to solve this, and increasing integration between health services and social services is very, very important. This is an area of integration between health and social care and social services is a very important area for us in WHO. And yesterday there was a high-level event on primary healthcare where our regional director made an intervention, and his intervention focused very much on this as critical for equitable rebuilding in the post-pandemic period, that we can do this better, we can do this meaningfully, and with a focus on being able to identify and reach the vulnerable in real time. And often primary healthcare is best positioned to do this. We just need to equip it with much stronger tools of population health management to know who these vulnerable are, and not just in a disease-specific manner, but in a more holistic manner of taking into account their health status, but also social status. So thank you for raising these points and prompting us. It's very, very important. Before I close this round, let me see if any of you would like to come back in on any of these issues of enhancing prestige, attracting people to primary healthcare, and more integrated holistic care, and your ideas. In fact, Shirin, I asked you after your intervention, is Kyrgyzstan doing this? Are primary healthcare practitioners involved in the governance of primary healthcare, in policy development? Would you like to come back in? And then I open the floor for any other one of you before moving to the final round.
Yes, thank you very much. We are moving, but we are moving very slow. And about the recognition of the family medicine as a scientific discipline, this is the third year when we are receiving rejection to recognize it, but we are still hope that one day the higher attestation committee will accept our discipline as a scientific specialty. And about the primary care workers at policy level, at ministerial level, we are now working for that, but still today we do not have representative of the primary care at ministerial level. So it's a wide area to fill these gaps, to improve image of the primary care.
Indeed, no, and you intuitively tapped into a very important point. And now, as we're working with countries on strengthening primary healthcare policy more proactively, the first thing we look at is, what is the governance mechanism? Is there a task force that's multidisciplinary of nature? It connects national and regional and local levels? And what is the composition of that task force? And one very important thought here is you actually mentioned this, and this was your central idea, is to connect the voice of practitioners to the voice of policymakers. And in fact, this is what we're also doing in our talk shows, right? We always, we're bringing in you guys, you're all practitioners, but in our previous talk shows, we also had practitioners to bring the voice of practice to policy and to move away from sort of the abstractions to very pragmatic considerations and practical action. So that's very good. Let me look at your colleagues. Anyone would like to come in additionally in this round? Wave your real hand, not your virtual hand. I can't see your virtual hand. Yeah, Katya, go for it.
Something that I would like to add is that pharmacists in the community are very at a very central point. So in a very fragmented system that in all countries exists, we can be the central point and be able to vet the medications of the patient and able to direct them to other healthcare professionals when they need, because we are at every corner. We are very, very close to them. We are in close contact with our patient. So if we make good use of our pharmacists, we can provide a better service in primary care, and also perhaps provide the ability, for example, to pharmacists, especially in other countries who have big areas, and in rural areas there are internal clinics and they have to travel a lot to hospitals. Perhaps pharmacists can be provided the ability of prescribing medications, especially for urinary tract infections, for minor illness, which are prescription-only medications, but they would be willing to provide the care and actually be of a greater service to the patient, because they don't have to travel a lot for such such not serious condition. You know what I mean? So yes, I think if we provide more, if the pharmacist is given the ability, the trust to provide the service to the patient, I think it would be a very strong link in the network and provide a better service to its patients. I think that is my idea.
Yes, I think that's a really great point, right? And as we move to larger multidisciplinary networks that really truly work together, we have much greater opportunities to redefine roles and responsibilities in a more flexible way than what we have today. Today, we tend to think in terms of these rigid norms of how many family doctor per population, et cetera, But what we saw during the pandemic is a tremendous adaptation at primary healthcare levels, where we were pushed to shift roles and responsibilities. And I think it's very important to learn from that. In fact, we have launched a series of country vignettes recently, where we are describing the experience of 15 countries with the transformation of primary healthcare during the pandemic. And quite a few of the vignettes focus on how tasks shifted at the primary healthcare level, from specialists to generalists or family doctors, from family doctors to nurses, to community pharmacists and administrative assistants. And it's very important to draw the lessons from this of what can be done and systematize that in the future, so that we have a much more agile, flexible way of providing primary healthcare services than in the past. So thank you for prompting my own thinking on that. And my colleagues are pasting the link into the chat where you can find our country vignettes. And over the summer, we will be publishing week by week more and more country experiences going into the fall. I'm going to look back at you. If you, any hands up? No, then let's come to our closing and final round. And this is going to be an elevator speech. I will give each of you 1 minute to make an elevator speech. If you were the Minister of Health of your country, what would be the top 1, 2, 3 changes or policies you would put in place to strengthen primary health care? Ready? Katya, you go first.
Okay, so I would add pharmacists prescribing, increase this point of care testing in pharmacists, perhaps implement the direct channels of communication with our GPs and healthcare professionals, and perhaps make it mandatory for more continuous professional care CPDs for the pharmacists, so that we can do and provide better services to our patients. But also, I would like that it would move further than just patient-centered care to a more family-centered care, that the carers who are taking care of the patient are included in the care plan. that would be my vision, I think, for if I had to be a Ministry of Health.
That's great. I would love to live in the country where you are Minister of Health. That definitely spoke to me. Very good. Andre, you're up next. Your 1 minute starts now.
Yes, I think I would be focusing on the things that I've already mentioned, especially on the thing that I will create somehow with my team, of course, not by myself. Easier access to health services, to social services, to any kind of services for everyone. And I think also bureaucracy in our country is like not helping. So yeah, these are the things I'll be focusing on.
Yeah, very, very good. Thank you very much. Stephanie, what would you do if you were Minister of Health?
Yes, I would start with enforcing the understanding of that there is a lot to learn in the primary healthcare, both in basic training but also in the specialist training. Then I would try and break down some of the silos in the organization, so that it would be easier to work together within the organization. And then I would set some norms for the number of primary healthcare nurses that was required within each community.
Very good. And Shirin, you get to close the panel.
Yeah, it's really good question, and I'm thinking what it should be that one thing and that I can focus on. I think I would recognize from family medicine like a scientific discipline, just to start the research on primary health care, to show how it could be the real effective care for everyone, and how people can benefit in strengthening the primary health care, and how it can also benefit for government to have a strong PHC.
Thank you very much for these thoughts. They're very, very powerful. And in fact, I very much enjoyed this conversation. I think we got into the depth of some very important issues in strengthening primary healthcare. And I liked your fresh ideas and your fresh look as young professionals practicing in primary healthcare. I want to thank for your time, for being with us today and sharing your thoughts. We know that this is kind of a high pressure environment and endeavor for you, but we very much appreciated it, and our viewers very much appreciated it. And I particularly like that this was our season finale. We launched our talk show series in December, and I want to thank all of you, our viewers, who have been with us through these 6 talk shows. It has been a real pleasure, and it has demonstrated to us that there is such eagerness to continue to talk about primary healthcare and the transformation of primary healthcare. We have reached over 40 countries, and with the 6 talk shows, over 1,200 viewers. So that's really fantastic. We have also enjoyed that you always stayed on, or many of you stayed on, for our breakout sessions, and I will announce them in a moment that we will continue with that as well. We're going to take a well-deserved summer break, and you get to have a summer break as well. And we will be back in September for our season 2. And we will announce through our newsletter, to which you're subscribed to, what will be the main topics. And we really look forward to seeing you. And now I would like to invite you to join our breakout rooms. We will have 2 breakout rooms, one in English language and one in Russian language. And we would like to hear from your experiences. I know that there are lots of other young professionals online watching us today. We would like to hear from you. My colleagues are pasting in the chat window how you can join the breakout sessions. There are 2 separate links. And when you close this main window, you will receive a pop-out window with a short survey on how we did today and asking also for your suggestions for future topics. Please take the 2 minutes it takes to fill that out. Your opinion really matters to us. And with that, I say goodbye for now, for this talk show, for this season, and I see you in the breakout rooms, or I'll see you in September.